Good evening, ladies and gentlemen. I feel very privileged to present my lecture here. And my topic is about the clear orthopedic approach, S8 SGTB, in correcting severe jaw discrepancies. S8 SGTB is a kind of clear version of sagittal guided twin block. It is invented by Professor Shen. 5 years ago, Smartee, in conjunction with Professor Xing's Orthodontic group, to develop the clear version devices to treat the jaw discrepancies. And since then, S8, S9, S10, S11 has been launched one after another. And today, I'll show something about S8. This is the content that I want to share with you. I will show you what is the Smartee S8 SGTB and the indications of S8 SGTB, and why can we achieve the treatment outcomes with S8 SGTB, and how can we to use it, okay? And this is the first part. What is S8 SGTB? S8 is the version number for mandible repositioning technology in Smartee. And SGTB means sagittal guidance twin block. It is a kind of clear aligner and includes anatomical occlusal splines. The occlusal surface of the splint is not flat. It has the anatomical shape like the teeth covered by the splint. This anatomic surface can let the occlusal contact more stable when the patient wear the aligners. So the S8 SGTB needs to be worn during the meals. And the point is very, very important. And the height of the splint can be changed as needed during the treatment. We often tap down the height of the splint to help the flatten of speed curve in our animation. And for lower aligner, it includes locking appliances. The anatomic occlusal splint and locking appliances all have interactive surface. When the patient wear the appliances and bite together, locking appliances on the lower liner would touch the interactive surface of the anatomic occlusal splint, and it would help to force the mandible move forward, just like the conventional version twin block. The difference is S8 SGTB is more comfort, and it allows the mandible advancement and teeth correction simultaneously. So it is more sufficiency. And the second part is the indication of S8 SGTB. In our clinical practice, we may encounter some cases whose chief complaint is facial prognathism and want to improve the facial profiles. Let's check these 3 cases. We can find that they are all facial prognathism. When we cover the jaw, their maxillar protrusion is accessible, right? But if we show the jaw, the facial profiles are protruding. And we believe that all these 3 cases are always mandibular retrusion. And the mandibular retrusion makes the face more retruding. When we do examination, we may find they have the same manifestation in their mouth. Okay, this is case 1. A class 2 version 1, we can get class 2 molar relationship, deep overbite, deep overjet, and deep speed curve. and excessive perclination of the upper anterior teeth, crossbite of the left first premolar. Case 2 is also a class 2 version 1, and we get class 2 molar relationship, deep overbite, deep overjet, and deep spit curve. What is different is that the relatively upright of the upper anterior teeth and the crossbite of the second molars. And this is case 3, a class 2 version 2. Class 2 molar relationship, deep overbite, deep spit curve, and no deep overjet, right? But we can find the retroclination of the upper anterior teeth, which means the overjet has been hidden by the anterior teeth compensation. So we can find that these 3 cases have the same feature. Protrusive facial profile, class 2 molar relationship, deep overjet, deep overbite, deep spit curve. As mentioned before, these 3 cases are always the mandibular retrusion. We can call this as jaw discrepancies, right? And the corresponding oral manifestation are class 2 molar relationship, deep overjet, deep overbite, and deep spit curve. And vice versa. If we find a case with the same manifestation as class 2 molar relationship, deep overjet, deep overbite, deep spit curve, may be indicating severe jaw discrepancies. We can classify them into 3 types of facial prognathism that include mandibular positioning factors. As mandibular positioning originated prognathism and combined skeletal and mandibular positioning originated subtype 1 and subtype 2. This is a new classification method for facial prognathism, also comes from Professor Shen. We have 5 kinds of classification for facial prognathism, and 2 basement classification as dental alveolar originated and skeletally originated. These 2 classification with class 1 molar relationship. And another 3 types of facial prognathism that include mandibular positioning factors with class 2 molar relationship. At present, most of the therapy for these 3 cases are carried out by extraction, dental compensation, just like molar distalization, or by maxillofacial surgery. But it is very complex for extraction. And the treatment takes a long time for molar distalization, and the surgery is invasive, risky, and expensive, especially the extraction. Sometimes it is very difficult to leveling the curve speed and correct the deep overbite. So the extraction space cannot be closed easily. Sometimes we may try to use mini screw to help us to correct the deep overbite, but it is still difficult. Is there any better way to solve such cases without large amount of teeth movement, like distalization or tooth extraction, and improve their deep overbite and overjet, achieve class 1 molar relationship, and improve the facial profile simultaneously? And we can choose mandible repositioning technology and use S8 SGTB to move the mandible forward and align the teeth. Okay, next part is why can we treat these kinds of patients with S8 SGTB? The key factors for successful treatment will be a rigorous diagnostic classification and a condyle remodeling ability, stable occlusal relationship, okay? First one is rigorous diagnostic classification. As mentioned before, these three classifications of facial prognathism have the same clinical manifestation as protrusive facial profile, class 2 molar relationships, deep overbite, deep overjet, and deep spit curve. And all of these characters are indicating a severe jaw discrepancies. Pay attention. It is jaw discrepancies, but not hyperplasia or mandible. Why? Why is the discrepancy but not the hyperplasia or mandible? Because when we measure the length of the mandibular body with the drawback analysis method, we can find a phenomenon. I show that. This is a set of case 1. We can find the length of the mandible body is within the normal range, but A and B is more than 6. And this is case 2. The length of the mandibular body is normal, and A and B more than 6 too. And case 3 is same as case 1 and case 2. The length of the mandible body is normal, but A and B is more than 6. So this is a hyperplasia? No, they have the normal mandible length. So this is not the hyperplasia, which means maxillofacial surgery may not be the only right way for these 3 cases. And please don't focus on A and B, okay? This is not the hyperplasia. And I show these 2 cases. These 2 cases have the similar A and B, more than 6. But the morphology of the mandibular body is different. The first one is rectangular, and the chin point is prominent. And the second one is triangle. The chin prominence is quite compromised. It's going backward, okay? We may call the first one as mandibular retrusion, and the second one as skeletally originated. Today, we focus on the first one, the mandible retrusion. Okay, let's back to our 3 cases. We call these discrepancies as mandible retrusion, but not hyperplasia. It is the thing about the position of mandible, but not about the development. Except for its length, the mandibular body morphology is healthy, flat, rectangular. The chin point is prominent, which means if we can move their mandible forward, their facial profile will be improved. Okay, this is rectangular. Except the maxillofacial surgery, if we want to correct the molar relationship from class 2 to class 1 by moving the teeth, it is not an easy task. The treatment philosophy for these 3 kinds of cases should be based on the jaw discrepancies coordination rather than correct the teeth first. And that is a very important philosophy. We always have the teeth correction first, And then it would be very hard if the malocclusion have some mandibular position factors. The second factor is condyle remodeling ability. 20 years ago, Professor Shen began his research on condyle remodeling. And this paper was accepted by JDR in 2005 as a cover article. This paper shows some of the study results and review about the adaptive remodeling of the condylar cartilage. Mandibular condylar cartilage is different from the cartilage of the long bone in many ways. The most important difference is condylar cartilage could be remodeled in the response to the external stimulation during or after natural growth, which means we can also treat the adults with mandibular repositioning technology. By 2022, more than 20,000 cases has been completed by SGTB in China. And we find some evidence from clinic. For radiographic evidence, new bone formation to the condyles is very distinct evidence for TMJ remodeling with SGTB therapy. And this is similar to the conclusion of many research papers. But in those researches, they use Herbst and twin block. We can see this is the CBCT of SGTB. On the sagittal view, we can find the new bone formation, okay? And the coronal view, we can find the new bone formation, okay? It's here, okay? And we call this SGTB condyle. We can also find evidence on MRI. MRI could show the boundaries of the newly formed bone more clearly. Here, this is the new formed bone, okay? Last part. Last part is we can achieve the stable occlusal relationship. Okay, let's look at this patient. After we move the mandible forward and reach a new jaw position, the case-to molar relationship has been converted into class 1 and is very stable. So we don't need to need a large amount of teeth movement like distalization or teeth extraction. Okay. Therefore, the key factors of SGTB is rigorous diagnostic classification, condyle remodeling ability, and stable occlusal relationship. Okay, last part. I show you how to use SGTB. There are two phases of SGTB. Phase 1, we advance the mandible with the help of SGTB for 10 months. We ask the patients to wear this appliance all day long, even in the meal, because the advancement of the mandible must be continuous. At the same time, with the help of clear aligners, we could do some individual teeth correction from the very first day. Phase 2, as well as the mandible could stay at this new position steady and stable. The molar relationship has been corrected from class 2 to class 1. So the phase 2 is much simple. We just do the intercuspation of the teeth and some detailings, the midline, overjet, overbite, or something. Now, take a look at the real case of SGTB. Firstly, I'll show this one. Let's take a look at this treatment process. This is a 20-year-old male with a facial prognathism, and the chief complaint is the teeth not aligned. But basically, symmetrically facial profile and deep labmental frown. The intraoral examination is class 2 molar relationship, deep overbite, deep split curve, and no deep overjet, right? But we found the retroclination of the upper anterior teeth and crowded updentation. OPG shows 3 wisdom teeth, and the shape of the condyle is accessible. The lateral safe showed a normal mandibular border length, and the morphology is flat rectangular. The chin point is prominent. And we can find a severe jaw discrepancy of mandible retrusion. Before the SGTB appliance was available, a molar distalization was designed to obtain space for adjustment of the dentition and intrude the anterior teeth to improve the deep overbite. But we have 70 steps animation. Okay, we can see the animation, 70 steps. It will be a long time, right? And at the 27th stage, there were still changes in the facial profile, okay? Because this is the clear aligner, right? And at that time, there was still deep overbite and hidden deep overjet and deep curve speed and class 2 molar relationship. So it is no change, okay? And the OPG, the safe tells that the changes are not significant. And at that time, we got SGTB. So we adjusted the treatment plan to mandibular repositioning. Okay. Firstly, we obtain a new jaw position by wax, just like this. We buy the anterior teeth, incisor to incisor, right? Okay. During the phase 1 of the mandibular repositioning, while applying the SGTB to perform the mandibular advancement in blue, okay, and adjust the, we can do some teeth movement or correction. We do the adjust the arch form and to match the arches of the maxilla and mandible, and level the curve of speed. Intraoral photos of wearing SGTB shows that the stabilize the mandible position as a simulated one. Okay. At the end of the phase 1, we got a stabilized jaw position, and the mandible can't bite backward. The molar relationship is class 1, and deep overbite and hidden deep overjet has been corrected. The retroclination of the upper anterior teeth are controlled and resolved. The curve has not been completely flattened, so there was a posterior open bite. And at this time, the phase 2 treatment started. We will do something to get the occlusal contact. It is mainly designed in phase 2 to achieve normal occlusion and align the teeth finally. Okay. After the treatment, we can get class 1 canine and molar relationships, normal overbite and overjet, and stable occlusal relationship, right? Okay. And the facial profile improved, a natural and harmonious facial profile achieved. So SGTB pulled me out from a long time hold teeth moment. Okay. Next one. Let's look at this treatment process. This is a 24 years old young lady. And her chief complaint is misaligned teeth and protruded facial profile. We have 3 days. Again, deep overbite, deep overjet, and deep spill curve. And the molar relationships are bilaterally class 2. And indicating the mandibular translation backward, right? And crowding dentition, back cross bite of the bilaterally second molar, and upright of upper anterior teeth. Take a look at the OPG. The physical counter of the condyles are accessible, and the mandibular body morphology is quite favorable. Flat rectangular, and the chin point is prominent. Okay. Together with the facial profile analysis, we come to a conclusion that this case is malocclusion with facial profile with the facial prognathidum, and mandible retrusion and the diagnosis combined subtype 1. Okay. So what would you do for this case? Distalization? No, it takes a long time for molar distalization, and I don't want a 70 steps animation. And it barely helps with the correction of molar relationship, but not for the facial profiles. Extraction? No. It is very difficult to flatten the deep curve of spin. And surgery, it's we just said that it's invasive, risky, and expensive. Okay. So how do we do? We can choose SGTB because the prognathidum of this kind of patient with the positional element, and that is the mandible retrusion. Okay. So firstly, we obtain a new jaw position by wax, and then SGTB in blue will be designed to achieve mandibular advancement. And we will correct the dentition simultaneously. Let's check this animation. Sagittally a bit more distalization to help the correction of buccal crossbite of the second molar. And vertically leveling the curve of speed. We do intrude the lower anterior teeth. And horizontally, we do maxillary expansion to match the width of new mandible position. And correct the buccal crossbite of the second molar. And we can find the crossbite of the second molar will be correct easily when we open the bite. When we open the bite with SGTB. Okay. With the accomplishment of the stage 1, the molar relationship, deep over bite, deep over jet has been correct. And the crossbite of the second molar, correct. What we have is only a limited open space in the buccal segment, right? Okay. The second stage is much simple. What we should to do is reach the occlusal contact of teeth, also the vertical movement, intrude anterior teeth, extrude the posterior teeth, and align the teeth finally. Okay. And when we finish this case, we get class 1 molar relationship and good occlusal contact and aligned the dentition, centered midline, and coordinated arches, no space. Okay. Look at the OPG again. If you look quite closely at the condyle, both sides of the condyle bone formation is quite evident. Okay. And the position of the mandible move forward. Okay, we correct the overbite and the overjet by move the mandible forward, but not the protrusion of the lower anterior teeth. Okay, and we do the upper anterior teeth retroclination. Okay. Let's review this patient. 10 months to reposition the mandible, and next 9 months to finish the treatment. And the facial profile has been improved significantly. Okay. And these 2 cases are adult. And for the last one, I'll show you a teenager. This is a 14-year-old girl. And the chief complaint is protrusive lips and retrusive chin with crowding teeth. And the facial profile is facial prognathism. Okay. According to the case stage, we can find crowding of upper and lower dentition, and deep overbite, and anterior teeth retroclination, which means a hidden deep overjet, right? And deep curve speed we can find from the OPG. And class 2 molar relationship. And the shape of the condyle is variable. The retrusive mandible. And the mandibular body morphology is flat, rectangular, and the chin point is prominent. Okay. So this is the same manifestation. Protrusive facial profile, class 2 molar relationship, deep overjet but which is hidden by the retroclination of the upper anterior teeth. And the deep overbite, deep curve of speed. So no distalization, no extraction, no surgery, right? And of course, I will choose SGTB. Firstly, we obtain a new jaw position by wax. And then SGTB in blue will be designed to achieve the mandible advancement. This is the same, okay? And we will correct the dentition simultaneously. Let's check this animation. Sagittally, molar distalization, a bit molar distalization, and correct the retroclination of anterior teeth. And I will say that we can do a bit molar distalization when we win the first one, and we don't need to encourage because when the patient bite together with SGTB, the interactive force will help us to enhance the coverage of upper anterior teeth. So we can do some molar distalization when SGTB was worn in mouse. Okay, and the retroclination of upper anterior teeth is very very important for this kind of cases, because these kind of cases have the retroclination of the upper anterior teeth, but we can't to correct it to the normal, right? If we correct the retroclination of upper anterior teeth to normal, the facial prognathism will be very significant. So we can do that. So we do the upper anterior teeth, control it and correct it, okay? And vertically leveling the curve of speed, and we do intrude the lower anterior teeth, and we also lower the height of the splint. You can see when the animation to let me check. Okay, here to 22, the height of the splint was tapped down to help us to level the speed and let the posterior to leveling, okay, and to intrude the lower anterior teeth, and so we can let the speed curve will be leveled, okay, and horizontally maxillary expansion. Pay attention, we expand the upper arch, but not the palatal. Why? Why is the upper arch? We expand the upper arch, but not the palatal, because we can check this patient. The posterior teeth of maxilla is also retroclination, right? We can find that. The posterior teeth of maxilla is also retroclination. So what we should do is to expand the upper arch, but not the palatal, and that's enough to match the width of the lower anterior teeth. The new position, lower anterior, lower arch. Okay, and this is the result of phase 1. And we get a stabilized jaw position, and the molar relationship is class 1, and deep overbite and hidden deep overjet has been correct. Okay, and the retroclination of the upper anterior teeth were controlled and resolved. It's very important for subtype 2. Very, very important. And the curve has not been completely flattened, right? So there was a limited open space in buccal segment, okay? Okay, for phase 2. What we should do is a occlusal contact of teeth and also vertical movement to intrude the upper and the lower anterior teeth and extrude the posterior teeth and align the teeth finally. Okay, because the dentition is crowded, so the steps for the phase 2 is 40, is 42. A bit more time, okay, and align the teeth finally, okay. So this is the result of phase 2. Everything has been corrected beautifully. Class 2 to class 1, right? And overbite and overjet are correct. And stretch curve of speed. And the upper anterior teeth is correct and the controlled correct, okay? Let's review this patient. 10 months to reposition the mandible, and the next 10 months to finish the treatment. Totally 20 months. Okay, but if we use the molar distalization, maybe we can't finish this patient within 20 months. And if we do the extraction, I can't think out check out how many times, how many months we can use to correct this patient. Okay. And the change of the facial profile is significant, and the facial prognathison was correct. Okay. The mandibular position has been moved forward a lot, right? And the overbite, overjet correct is didn't by the compensational teeth is all the most position is the most factor is the move forward of the mandible, right? Okay. Now you see SGTB is effective and efficiency. And if you feel that is that the classification is complicated, just memorize very simply about the indications of SGTB. Protrusive facial profile, class 2 molar relationship, deep overjet, deep overbite, and deep of speed curve. Okay, that's all. That's all about my lecture.
Dr. Wang, there is one question from the audience in the Q&A section asking the patient should wear them 24/7, but usually patient will change the clear aligner each week.
Yes, we need the patient to wear the aligner during meals and maybe not 24 hours, but he needs to brush the teeth, right? And but if and except for if we didn't brush the teeth, he will wear it and all the time, and especially for the meals. And just as I said in the lecture, and we need the continuous force to move the mandible forward to obtain the new new position for the mandible. And I think it is very important to wear the aligner when he have it. Okay, and we change the aligner per week, because we can the total time for the repositioning of the mandible maybe 10 months, and we can provide the aligners to the doctor and for the patient, and it's enough for the for 10 months to correct the position of the mandible. So we need to wear the aligner, and because we need to have the meal to wear the aligner. So change the aligner per week. I think it is right, and we do it just like this. Okay.
Thank you, Dr. Wang. And we got more questions in the chat. The first question asking, will extraction make the case more difficult to reposition? Will it take longer time?
Yes, just like this one, because when the deep speak curve and deep overjet, deep overbite, and we can't to leveling the speed easily. So if we can't level the speed, the extraction space can't be closed easily, because the anterior teeth will butt together, and so we can't close the spacement, so the space of the extraction. But if we use the SGTB to open the bite and get a new position, we will find the speak curve will be leveling easily. So if a patient needs to extraction, but he get the mandible retrusion, I think I will do the mandible reposition first, and then do the extraction. Okay, so I didn't do the I want to do the extraction first. I will do the mandible reposition first, and then extraction. Okay, this is my answer.
And the last question asking, so the doctor, I have done similar case with GS, but the molars were not extruded as much as per 3D design. Why this happened?
I think this is this patient will when we do the animation, extruded of the molar, it is a question, because it will we will check the face, because the height of the face of the lower face is very important. Sometimes if we do the extrude of the molar, it will let the mandible clockwise. So if you want the extrude of the molar, you can let us know, and I will let my designers to do this animation. But I think it is important for the doctor to check the patient of this of his height of the face, especially the lower face of the patient. It's very important. But if you need the extrude, you let me know. Let us know. I will check it. Okay.
Yeah, you can always keep in touch with us and we will answer those questions you may encounter in your clinical practice. And one more question, Dr. Wang, in the Q&A session, asking what if the lower incisors are already protrusive, which may cause the curve of spine not deep from the start? Will it still be an indicate for S8 SGTB?
It's a good question because for all the mandibular retrusion, mandibular repositioning technology, the lower anterior teeth will proclination because the interactive of the interactive factors of the upper and the lower arch, and the force will push the mandible forward, but the force will also push the arch, the lower arch forward, the forward, right? And if you don't want if you don't want the lower anterior teeth proclination, you need a mini screw to help to enhance the coverage of the lower anterior teeth. Okay. I do many I use many mini screw for the SHSGTB. Okay.
Thank you, Dr. Wang. I haven't done such cases before, only diastema and space closures. In such case, in how many weeks do patients change their aligners?
I just said that if I let my patient to change the aligner per week, but sometimes I will let the patient change the aligner 10 days. So 7 to 10 days, I think is enough. Okay.
7 to 10 days.
Mm.
All right, so I think that's all the questions we got and we answered all of them. All right, thank you, Dr. Wang. I think those are all the questions we have for now. So yeah, so this is all for today's session. And actually, this is the last session of the Smartee International Academy webinar this year, and concluding a wonderful series of online courses presented by those our inspiring Smartee lecturers at home and overseas. So if you'd like to review those lectures and also to keep in touch with us to follow, to know more about our upcoming agendas for the next year, please feel free to follow us on our social medias, Facebook, LinkedIn, and Instagram, and YouTube. We will keep in touch with you. And yeah, so this is all for today's session. And we are looking forward to see you next year, everyone. Goodbye.